Hello, my name is Rhonda Brune, and today I will be discussing advanced practice issues of nurse practitioners. My topic today is prescriptive authority. Advanced practice nurses, also known as APNs, are regulated by the state in which they work, which determines their scope of practice and prescriptive authority. While physicians universally enjoy the least restrictive scope of practice regulation, APRNs have more variability in autonomy and authority. Restrictions placed on APNs not only limits the practice capacity of the nurse, but also severely impacts populations who are underserved and promulgates the shortage of mental health providers in rural areas. Now, if you could turn to slide 2, we'll discuss the definitions of prescriptive authority for advanced practice nurses. Currently, there are 22 states that allow APRNs to have full practice authority, permitting prescribing authority of controlled as well as non-controlled drugs. They're also allowed to evaluate, diagnose, order, and interpret diagnostic tests, and to initiate and manage treatments. 16 states have reduced practice capacity, which limits at least one element of the nurse practitioner practice. 12 states severely restrict the practice of nurse practitioners with career-long requirement for collaborative agreement, delegation, or team management. Interestingly, none of the southern states have allowed nurse practitioners to have prescriptive authority. If you could go to slide 3, we'll discuss the challenges and benefits of a collaborative agreements and restrictive authority. Collaborative agreements serve as limiting factors that are governed by statutory laws and to some extent gives the collaborating physician authority to limit the nurse practitioner's scope of practice. Collaborative agreements are vaguely defined and poorly understood, thereby increasing misunderstanding of the requirement for the collaborating agreement. One physician writer has wrote regarding collaborative agreements that they were implemented to hedge against rather than to promote collaborative practice. Although collaborative agreements have existed for decades, most are shockingly vague, rarely addressing more than proximity of practice, availability of mentorship, and hours of supervision. Therefore, we see that collaborative agreements are not financially feasible, increases administrative burden, and decreases mental health access. Placing an advanced practice nurse who has obtained additional education, gained advanced clinical experience, and has passed national certification under the authority of a physician gives an unjustified hierarchical structure, which is misleading to the public and creates inequitable status for the APN, who is an independent provider with recognized national standards for full scope of practice. Now, if you could turn to slide 4, we discuss the benefits. PMHNPs who have full practice authority have demonstrated double in number of patients seen and treated in community health clinics versus their counterparts who have limited practice authority. Over the last 25 years, APNs have shown improvements in reducing mental health-related mortality in the rural population, as well as improved self-reported mental health improvements in the disadvantaged population in rural health. The IOM also endorses the skills of APNs and recommends APNs to have full practice authority. On slide 5, we will discuss overcoming challenges of restrictive practice. One of the key recommendations of the IOM Blueprint for the Future of Nursing calls for full partnership with physicians and other professionals to have full practice authority. By collectively organizing with organizations such as the AANP and the APNA, we could advocate for political change to have full practice for APNs in all states, not just a few. To address concerns of physician colleagues, consumers, and legislators regarding fewer years of clinical experience of APNs, this writer advocates for a transition of practice model consisting of internship for 1 year after graduation to allow for close collaboration with a mentor, which will refine interviewing skills, shore up prescribing practices and dose adjustment skills, and offer a sense of confidence for the new APN. I also advocate for graduate programs to secure clinical sites and preceptors to ensure a robust, comprehensive learning experience. Most PMHNP programs require the student to procure their own preceptor and clinical site, leaving potential gaps in knowledge and experience that may not be realized until working in a real-world setting. Physician colleagues do not have this stressful undertaking and are able to focus on building skills, learning didactic content, and network with other healthcare professionals. In advancing healthcare delivery, it has shown that telemedicine has become a necessity forced about by the COVID-19 pandemic. It has also demonstrated that patient satisfaction and efficiency is improved when geography would otherwise constrain healthcare visits for rural residents. Telepsychiatry is easily and feasibly streamlined into an integrative healthcare model in rural primary care offices. In summary, full practice authority for advanced practice nurses remain controversial for reasons of safety, a well-established monopoly on healthcare workforce by physicians, as well as outdated political governance. APNs have a proven track record of safety and efficiency with better or equal outcomes to that of their physician counterparts. PMHNPs are able and willing to serve the rural population with demonstrated improvements in mental health outcomes. APNs have taken a national certification, which should allow them a universal scope of practice regardless of state boundaries. A few questions to address in the last slide there are, what practices will you employ